very nice to be here today, and I have the opportunity to speak about my dissertation that I defended in this very room. It's almost a year ago now, so it's nice to be back in a different capacity this time. I will be speaking to you about specifically two of my studies in my dissertation, and I am a bit of a rare bird in today's symposium. I'm a speech and language pathologist, and as such very interested not only in the functional voice, which is healthy and clear as the ones that we heard in Sverker's material, very nice healthy voices there, but I am very interested in the dysfunctional voice, the voice that doesn't work when it needs to work. However, I'm not interested as such in a very aesthetically beautiful voice. I'm interested in a sustainable voice that carries and that works for the person that needs it to work for her in this case. So I will be speaking about two of my studies, the first of which is called Recovery from Vocal Loading. And the material is based in patients with functional voice disorders, and functional voice disorders are the kind of disorders that makes somebody maybe not even sound very hoarse. You may sound hoarse, you may have a very disrupted voice like this, but that's not usual in the functional voice disorders, where the problem is mostly wear and tear of the voice, a feeling of strain of the voice, it not working in the working place, for example, for teachers who have great wear and tear of their voices. So when we look into the throat of the patients with functional voice disorders, everything looks clear. The vocal folds, which are the vocal cords, they look healthy, everything looks fine, but it's something in the use of the voice, in the behavior of the voice, that's not working for the person who needs it. So that's the main focus of today's talk. I did a very traditional dissertation with 4 papers, and I will be talking about 2 of them today. The first of which is called Recovery from Heavy Vocal Loading in Women with Different Levels of Functional Voice Problems. And I was supervised by Roland Rydell and Vivica Lyberg-Olander, which is one of the researchers who Frans Mossberg mentioned earlier to be a part of this symposium last time. Right. He was also the supervisor for Sverker Sadig. So we're sort of siblings, I suppose. Let's talk a little bit about the background. Very briefly, I want to talk to you about loading factors for the voice. So traditionally, we talk about duration of voice use. So using the voice for a very long time will strain the voice because of just mechanical wear and tear. But also background noise has to do with the wear and tear of the voice, because competing with heavy noise, as we heard earlier from the bazaar in Istanbul, for example, would be a good example of background noise which is difficult to use the voice in. But also the room acoustics, the voice is not something stationary within the body of a person, it is something that has to interact with its context. So for example, in this room, we have an echo within the room, which is pretty short, so I need a microphone to get to the back row of this room, which is something that probably was designed within the room. And also the quality of air, other ergonomics and psychosocial factors will affect a person's context in which to use the voice. And the individual factors will also cause risks for voice problems of this kind. So, for example, gender. Females are more common in our waiting rooms in the voice clinics with functional voice disorders than men are. It's about a 50% difference. And also, for example, the the choir singers that we heard just earlier, which were pretty unexperienced. They will increase their endurance as they go along and use their voice more. They'll get a better condition to their voice and be able to use it for longer. And other health conditions, life habits and vocal skills, training, for example, in the choir, and personality traits will also affect the individual capacity of using the voice. So this is mainly the background of my work. And what then is vocal loading? Well, traditionally it's using the voice for a long time and also using it with high intensity, very loud voice use is what we consider to be vocal loading, or röstbelastning in Swedish. I was interested in looking into musculoskeletal functions, general fatigue, and in and around the larynx, and also mucosal tissue in the vocal folds from vibration, and that's the actual vibration within the vocal folds when the voice is produced. And I was also interested in looking at increased, I was interested in looking into it, but vocal effort and vocal fatigue has to do with decreased auditory feedback. And then that's how we come back to the noise within the room, for example, the background noise, as I was talking about. Right, so in this study, and also in the next study that I will be presenting, I was looking into the vocal behavior of 50 cisgender female people. So cisgender is just pointed out so that these are female people who identify as being female, so they don't desire a different voice than the one that they have. And they were divided into 4 subgroups. So at the very base here, we have low everyday vocal loading in one group, voice healthy control. So these are just people who go out into their daily life, open their mouths, and out come their voices, and there's no problem. And they don't really need their voice for their work. They use it, of course, for making phone calls and taking part in meetings and such, but they don't use it as a main tool for their voice, such as teachers would, or a priest has to do, for example. In the next level up, we have people with, and women with, high everyday vocal load. Most of these were teachers, but still they didn't have any voice complaints. So they didn't have any problems that they'd reported with their voice at all. The next level up, again, into the orange here, people have high everyday vocal load again, mostly teachers. They have voice complaints, but they've never sought any treatment for them. So they haven't come to the voice clinic, but they have reported for themselves and noticed that, well, after a long day, I have a pretty sore throat, or I have a rougher voice quality, or something happens to the voice, and it mostly has to do with the feeling of strain. Sometimes they come home and they have difficulty swallowing, for example, because their whole neck is really tensed up from voice use. And in the top, which is novel for this study, is that I looked into the voice behavior of 20 voice patients from the clinic. We have very little research still that has followed vocal behavior within actual patients with voice problems that have come to the voice clinic themselves or been referred by an ear, nose and throat specialist or a phoniatrician to the speech and language pathologists to get help with their voice function. And as you can see, there is a pretty big age span, but the age span was thankfully very similar within the 4 groups. So what I wanted to see in this study was, obviously I had to induce some kind of heavy vocal loading. I had to make everyone use their voice a lot to be able to see what happens when you use your voice a lot. So that's the first objective. And the second was to track recovery time following a vocal loading task, which is when I induced the vocal loading. I looked at short-term and at long-term recovery through self-assessment of voice health. I did objective measurements as well of the voice, but I won't be talking about them very much today, because there is so much data, as all of you know. When you write a dissertation, I have to pick and choose what to present. And I pick and choose this because it's a very important aspect of voice pathology overall. We must ask the patient. We must check with the person. How is this affecting your life? How is this voice working for you? Even though I can see and I can hear that there might be problems, that might not necessarily mean there is a problem for the individual. So I mustn't create problems that are not there. And sometimes I can't hear it and we can't see it, and it's a massive problem for the patient. And that mostly indicates the complexity of voice health. My main conclusions, I'll skip to the end now, is that the short-term recovery is slower for patients with functional voice problems than the other groups. So this group stick out in the short-term recovery rate, but the long-term recovery rate is the same over all the groups. So what I did was, just to get a feel of the setup for the project, is I started up at day 1, got people into my clinic, had them put on some machinery that I'll show you in a bit, which has to do with the voice accumulation underneath, and I sent them home again. And I brought them back day 3 and did the vocal loading task, sent them home again for recovery, and then followed up 5 days to 7 days later. And I want to show you, or rather, I want you to listen to some examples of the patients taking none of these are patients actually, but 2 participants taking part during the vocal loading task. And I'll be talking about the actual task itself more in the next presentation. But I want you to listen to the voices during this vocal loading task, which I naturally recorded, and did lots of experiments on. But they are speaking in a nice quiet environment to start with. They have no background noise to compete with to start with. But I'll do a little jump within the recording, and after a while they have lots of background noise to drown out. So their task was to read aloud, read a text that they could choose themselves. It was supposed to be easy to read. I have not gone in at all to the cognitive aspects of this, which is another problem area in itself. But I let them read aloud. They didn't have to remember what they read. They didn't have to read correct. It was all right to skip words or whatever. I just wanted them to use their voice, to keep it going. And read aloud and drown out and make themselves heard over the background noise, which increased up to 85 decibels in the background. And that was optional. They didn't have to go on for 30 minutes. They were instructed to keep reading and stop when and if you feel a discomfort from your throat. Stop. She did not stop. Nor did the people in the functional voice problems with diagnosed voice problems group. They also went on for 30 minutes. So that made me think a lot about, well, why? Basically, why do you keep going when there's such a strain that we can hear. I think maybe some of you maybe even tense up listening to that voice. Well, yes. I'll come back to that discussion point later on, but I'll tell you, I had my participants work hard for me, and they were heroes to do this, all 50 of them. So what I did was I asked them, what is your voice status right now? Do you have any voice problems at all? On a scale from 0 to 100 millimeters, with one end of the scale being no voice problems at all, and the other end being maximum voice problems, cannot imagine anything worse than this. So right before the vocal loading test, which is the acronym VLT up here, just before, just after, then after 15 minutes, 30 minutes, 45 minutes, 60 and a 120-minute mark. So I've borrowed this setup from sports medicine to look at recovery rates after heavy and induced, for example, running or any kind of aerobic yeah, lost the word there, sorry. Well, so I looked at the short term, and remember that's where the functional voice patients stood out. So they did not recover during the first 120 minutes. They never came back to their baseline at T1, pre-vocal loading test. However, the long-term recovery showed no differences between the groups. And that was checked through a voice health questionnaire where I checked symptoms of voice problems such as hoarseness, soreness of the throat, the tendency to have to clear your throat, coughing, that kind of symptoms is what I mean there. And also the general voice health. Like I said before, how is your voice condition right now? And that was recording 4 times per day, so I could follow the long-term follow-up during the 5 to 7 days that they took part. Yep, already said this. There was no recovery during the first 2 hours for the patients with functional voice problems, but the long-term recovery was equivalent to others. And it's amazing how it even takes about 20 hours for somebody with a healthy voice to recover from this kind of vocal loading. What was interesting was, you remember, that was the T1, T2, 3, 4, 5, 6, 7. There was one group that, when I looked at the relative interaction of the voice assessments, the self-assessments of general voice quality, well, not voice quality, sorry, voice condition, there was one group that stood out, that had a markedly increased problem with their voice just after the vocal loading task, which then regressed very quickly. And I thought, oh yeah, that must be the functional voice problem group, right? Nope, it was not. This was the group that we heard, like the woman we heard first. She has high everyday vocal loading, no voice complaints. So that made me think, okay, does this vocal loading problem, which is inherent in functional voice problems, does that have to do rather with an disability to identify heavy vocal loading? Does this have to do with the ability to identify strain and loading in your body? We know that different people give up sooner than others. Is that because they have better feedback loops within their system so that they can feel what's a strain and what's not? This is an area where we know very little within voice research, and that's where I want to go on with my research. Yes, so what we need to think about in the voice clinic is, of course, to talk about with our patients the importance of frequent rests of the voice rather than very long rests of the voice. So that's the important take-home message, I would say, from this study, is that if you have functional voice problems, that means that you can't use your voice for what you want it for your work. You need rather have important short rests for your voice throughout the day, rather than work really hard and then have to have a day off. It won't be as effective for your voice, because the long-term recovery is equivalent to other people's. It's the short-term recovery that we need in this group. Yes. Oh, sorry. But again, this strong reaction to the heavy vocal loading. The group that really reacted the most was the group with the very sustainable and good voices. So that might indicate that a strong reaction to heavy vocal loading, identifying it and maybe stopping. There were other results also indicating that they changed their mode of using their voice during the vocal loading task. That might actually indicate good vocal health rather than the other way around. So that again implies that we have to talk with our patients about the possibility of actually feeling your body and not going on when you feel a strain. But that means you have to feel the strain before you can identify the problem, of course. This might feel very intuitive to you. This might be very sort of obvious things that, yeah, the people with voice problems, they need longer recovery. Yeah, we could have told you that. We didn't have to spend 4 years doing research and reaching these conclusions. But the fact is, there was no data on this at all. There's very good clinical evidence with good experience. From within the voice clinic, there's great experience, but there was very little noted and written about this. And I will tell you in the next talk a little bit about why. It has to do with technological advances, of course, of the ability to actually assess such a complex behavior as vocal behavior and voice use. Yep, that was the first talk.
Okay, thank you very much. This is so exciting, and we're really waiting for the next talk. So we just said that we be opening up if there's anybody who have any questions or comments after these first talks. So we are well in time now. The train is well in time.
Good.
Yeah. Sean, do you have a microphone? Yeah.
Thank you very much for a nice presentation. I guess you focus on the group women because of what you said in the beginning, because
yes.
they are like frequent, they are like 50% more cases reported. Yes. But if you may take a guess, those conclusions that you drew, to which stance can they apply to the group men, for example?
I can't answer that, I'm afraid, but it's a very, very important and good question, because it all has to do not only with the voice itself, which is different on a group level, of course, between men and women. There's an anatomical difference on a group level, which makes the wear and tear of the voice really different for men and women. So that's one problem to bear in mind. But the other problem, which is sort of a built-in problem within the design of my studies, is that I had all my participants sit down and do this task for me, and there is also a bit of a cultural difference between men and women on a group level on what you do in such a situation. Because I was really taken aback, actually, with the results that that the patients with functional voice problems, diagnosed problems, they didn't give up. They sort of just soldiered on. And we don't know what that has to do with yet. But as I said earlier, this also has to do with personality traits. And my personality traits and your personality traits somehow have to do with the fact that you're a man and I'm a woman, as well as a sort of myriad of other things. So I don't know, but I would like to know. But that means I have to find 20 patients with functional voice disorders that are male, and they don't come by that often. They're not as frequent. But thank you, that's a very good question.
Yeah, that's a very good question. I have a similar thought that you're really touching upon psychological aspects and maybe neurotics, and I mean, if it's about how we function. I mean, for the person who goes on and on, though the body says no.
Yeah. Yes, so that's one aspect, and the other aspect, of course, which sets my research apart from sort of the aesthetic view of the voice, which in singing needs to be very beautiful, but I don't need a beautiful voice, I just need a voice that is capable. So, I mean, we have a psychological problem. I don't know if I can call it a problem, but an aspect that makes things more complicated is that we use our voice to communicate. So I use my voice to express my personality to you within everyday contexts. So that's another layer of the aspects of the normal everyday functioning voice. Which is also psychological, of course.
Absolutely, and I think Joan's remark here about the gender aspects and the male voice. I was always amazed at the old former Prime Minister Olof Palme when he spoke like that. Something. I have not practiced speaking like Olof Palme, so but there's something to do with the male. With a male role or something, trying to achieve some sort of authority and by using a very stressed voice. And
and
that's also the whole package of a psychological...
There has been research in that area, of course, induced, I think, by Margaret Thatcher, within the realm of authority and voice, within politics. A deeper pitched voice marks more authority than a higher pitched voice will, because psychologically, again, and you were talking about the reptilian brain function earlier, a deeper voice without seeing the person marks a bigger body, and that's something to be afraid of, right?
Very interesting.
A bigger body is something to be more afraid of than a little body.
And some people don't really have that voice, but presses down whatever they have to.
But Margaret Thatcher was taught to speak like that in order to induce more authority. Yes.
Another comment? Yes.
Short question. Yes. In the recovery phase, what did you instruct the patients to do then, or was it just silence? Or
no, that was a very good question. Thank you. They had to go about their day.
Okay.
Yes, but and I didn't go into detail about the diary that they kept for the entire time. They noted what they did there, but that was free, that was open. So if they had to go back to work, they did, and if they went home, they did. But I took that into account when I did my analyses. But some of them were silent, some of them were never silent, as we will see in the next presentation. Thank you.
Part 2.
Part 2, okay. Great. It's wonderful to have the possibility to talk about 2 of my studies. So, the next one is called Long-Time Voice Accumulation during work, leisure, and a vocal loading task in women with different levels of functional voice problems. And, big surprise, it's the same women, the same groups, no difference. And the two experiments were set up at the same time, and I collected all my data at the same time. But this time my objective was to examine the actual vocal behavior and the self-assessed vocal health, not only within the setting of the vocal loading task, but that compared to their everyday life. So what they did during work and what they did during their free time, their leisure time, weekends and such, if there were weekends included. Otherwise, evenings with family or alone, not speaking at all sometimes. Right, so the population is the same as earlier, as I have described. And skipping ahead again, my main conclusions here is that yes, we know that vocal loading has to do with the time that you actually use your voice, the duration of voice use, and also the intensity to which you use your voice. Higher intensity, louder voice will induce more vocal loading, but what I could see in this study is also something that is pretty well known and grasped within the voice clinic, but again, there was no data on this, is that time, according also to pitch, adds to vocal loading. Speaking at a higher pitch is going to cause more vocal loading than speaking at a more relaxed, lower pitch. And again, patients recorded their voice problems across all conditions. And what I mean by that is I had them sent home with a little diary to assess their voice function, their voice condition, as I said earlier, and these symptoms that I also mentioned earlier. But they also just jotted down really quickly what they were doing. I was working, I was doing this and this, or I was free, I was off playing golf, I think, for example. Yes, the patients recorded voice problems across all conditions. And that means their problems, point number 2 here, the patients, they have problems during work, in the vocal loading task, and during leisure. So all the time, they have voice problems. They report voice problems all the time. And interestingly, the women with voice problems during work are the women who have reported voice problems previously but have not sought any treatment for them. So I saw this interesting group with occupational work-related voice problems, which we work a lot with in the voice clinic again, but we don't have a lot of data showing that this is an actual fact, that some people have no problem with their voice, go into work, increase their voice problems, and then go home again and decrease their voice problems. So it has to do with them at work or with the work environment, for example. As I mentioned earlier, acoustics are very important when looking into this. And acoustics related to the voice function is something that we work with a lot within the group that I'm a part of, but the acoustic factor is not included in this particular study. But they did not seek voice therapy, so what happened? Well, you'll recognize this. And what I would like to play for you now is just an example of the background noise that the participants had to endure during the vocal loading task. So this is what it sounded like. I think you'll have to decrease the volume again now. It's going to be a bit loud. So when they started reading in the vocal loading task, of course, everything was silent. It was nice and quiet in my studio. And after a while, this speech babble started airing in free field within the very small booth. And it increased from 55 to 85 decibels during about half a minute and stayed at 85 decibels for as long as they could endure the vocal loading task, which was, again, they could stop whenever they needed to. Most people didn't, which was interesting. Some of them did. Okay, so let's listen to the background noise. Thanks. If you could hear Larden, Darden, Darden, Sarden, Barden, that was right. There was no words, there was just speech cut up into little pieces, put together, so that it would be an annoyance to the person speaking. That was my aim. There was 12 North American speakers, both female and male. But no words were left within the cut-up remainders of that noise. Yes, so you'll notice that the voice accumulation underneath here is something that I skipped in my last presentation, so let's talk about that a little bit. That's where I mean that the technology that has been developed during the last decade has really helped the voice clinic a lot. There is a possibility now of putting an accelerometer and a microphone directly on the neck of the bearer, whoever it is, a patient or whoever, a singer it might be, and you send them home and you bring them back, and it's more or less like an accelerometer like the ones you use for counting your steps, so that you see that you come up to 10,000 steps each day, so that you keep fit. Only instead we count the number of oscillations of the vocal folds during a day, more or less. And that's transduced via the vibrations in the skin through the neck. So that's what they carried home with them, the voice accumulator, combined, paired with their diary, so that I knew what they did, because that's a very nice ethical consideration within the realm of voice research. The problem is, again, that we use our voices to communicate. I'm only interested here in the voice signal itself and the vocal behavior. And what I mean by vocal behavior is at what pitch we speak. Is it high and squeaky, or is it very low and bass? A bassy full sound. The sound pressure level at which we speak. So if you were very intense or if you were very softly spoken. And how much this varied during the day was also interesting to look at. I could also get a measurement out which gives you a percentage of how much time you've actually spent phonating or using your voice during a day, which was also interesting to see. So that's what I mean by vocal behavior. However, vocal behavior might, in other circumstances, mean different things. That's interesting in itself. Yep, this is the questionnaire, the diary I was talking about. They noted their activity, their general voice problems, and their vocal symptoms 4 times a day for about a week. And in the middle of that week, they came in for the vocal loading task, as you might remember. Here are some bars from the self-assessment of voice problems. I mentioned earlier, there was a little bar with from 0 to 100 millimeters. So the numbers here indicate the millimeters that they've come up to in the different conditions. So in the vocal loading task to your left, the VLT, the 2 bars are very much higher than the other 2. And that's the patients with functional voice problems and the high load some complaints. And as I said earlier, this doesn't match, right? I said the people with high load no complaints were the people with the highest voice problems after following the vocal loading, but that was a relative measurement. That was comparing with where they started, because of course the patients with functional voice problems have a high incidence of voice problems going in. They have them with them, coming into the voice studio, whereas the other people don't. So the difference is bigger for the other people. That's the difference between these two studies. So here we have just high black bars going all the way along across all conditions. And this is on a group level, I should say as well. So this was interesting to see that the white bar have problems when we induce vocal loading. Otherwise, there's no real problem. So I wanted to know why. Why is this a problem when they induce vocal loading? And there's a big difference then between work and between leisure. Right, let's look at the pitch and a little bit into the behavior of the voice. There's a very high bar. 315 hertz is the pitch at which, at an average, people with high everyday vocal loading and some complaints spoke at in the vocal loading task. So that's how I can draw my conclusions that high pitch might have to do with heavy vocal loading and the sense of heavy vocal loading as well. For example, then going back to this chart. Looking to the left here and to the left here. There's a big difference. So there's something in the vocal behavior within this group in heavy vocal loading that happens. Right, and going forward, I thought it was interesting to see as well that during the work leisure, that these women who have a very high pitch, and I mean they speak about, I think this is about more or less where they are all the time, this kind of pitch, instead of down here where I am at about 200 hertz when I speak like this. And the average male voice would be about 100 hertz, just to give you some kind of feel for this, these measurements. 315 at an average is pretty high, although we do expect higher pitch range in the free field than within the studio, where you just read really softly and very relaxed like this. But there was also a significant difference between this group and their controls within the work environment. This is also novel data. We haven't seen anything like this before. But when we look in the leisure bars, everyone's pretty much doing the same thing. Yep. So that's how I reached the conclusion that vocal loading not only has to do with intensity and time, but it also has to do with pitch across different conditions. The voice patients that come into the voice clinic, they report problems across all conditions, and women, that there seems to be a real group of patients, rather not patients, sorry, women with occupational voice problems that needs to be tended to and looked into at the workplace. This is a problem related to work, not just to the person owning the voice. Again, the voice is not only in the body, it's also external within the context in which it needs to function. So, why don't they then seek help for their voice problems? They seem to speak more, they seem to speak at higher pitch, they seem to report significantly more general voice problems, but only during work. So, again, this might have to do with the time for recovery. Some people need longer recovery time than other people, and these women did not report the longer need for recovery time as the patients did. So this might seem like nitpicking and very sort of detailed, a detailed mapping of different voice problems, but this is how I think that we need to work in order to rule out who needs help and who doesn't need help, and also why we need help. And knowing why people need help with their voice function helps us, obviously, to know what to help with, how to help them as well. So that was all for me. Thank you.
Thank you, Susanna, for this fascinating journey into the human voice.
Thank you.
You're doing an incredible job up at the department where you are and the voice group. Great. Do we have any comments, Jean?
Yep.
Cheers again for a good presentation of part 2. I have a question regarding the voice logger. I mean, a voice of a person is, of course, we have a timbre, so it is characteristic from us, but the frequency that we create, it also depends on the words that we pronounce.
Yep.
So my question is, how that frequency, fundamental frequency that you call there, that you presented,
yes,
how is that calculated? You have like a time signal of the voice during the whole day, then you do an FFT of that, and you which frequency do you take? The lowest peak or the highest peak in the FFT?
Thank you. The logger does an estimation at a time frame or a time window that I decide on beforehand, and on the very long measurements like this, it did one every minute, making an estimation through FFT using not the lowest frequency, because that means that we would get a lot of vocal fry getting into the signal, but rather I put in a span, a lower and a higher span of frequency range, having measured the voices beforehand, knowing more or less where they would be, excluding vocal fry, excluding really high peaks, and then the program has an algorithm working out more or less what is the most plausible F0 every minute. Yeah. So it goes in stages, but it's a built-in algorithm that does that measurement. Yeah. Is that? Okay, yeah, thanks.
Some advanced calculations there.
Yes, yes.
Any more comments to Susanna? Yes, we have.
Thank you for an excellent presentation. It's super interesting.
Thank you.
I was wondering if you had, did you discuss this with the patients afterwards or with the study group? And what were their response? I was just curious if there is also, if people themselves mix volume with pitch, this thing of increasing pitch when...
Yes. Yep.
So what were the responses?
Yes, I did supervise a master's thesis going into actual in-depth interviews with some of these women who took part in my studies. And again, what's coming through, what's sort of shining through is this feedback system, a problem with the feedback loop from the voice through the auditory feedback systems, but also the sensory feedback, not only the auditory, but them in some kind of interaction. Obviously, we didn't ask the questions phrased like that, but that's what I was sort of looking for. So what we can notice is that some of the women in those 20 women in the black bar there, functional voice patients, have no real clue as to how the voice sounds in comparison to how it feels. And I don't know this. Some of them are singers, sort of, none of these were obviously trained singers at all, but some sang in the Sunday church choir sometimes. And I think that we could find that within this group have a higher incidence of people who can't carry a tune, for example, who have some kind of problem musically. But that's that's not included in the criteria at all for the diagnostics. But we're sort of getting into it, but we don't know yet still. But it's a very interesting and important question. We need to know more.